Committee. So today's meeting is officially called to order. And let's begin. I'd like to propose a motion to adopt the minutes of the Mnpa committee that was held on July 11th, 2022. So let me do that individually. Dr. Pagan?
Yes.
And Sally Hernandez-Pinheiro?
Yes.
And Dr. Martone?
Yes.
And I'm a yes as well, so the minutes will carry. And
excuse me, and Matt Siegler is on in a voting capacity.
Excellent. Okay, good, Matt. I didn't see you. All right. And lastly is Matt Ziegler, who's actually representing Dr. Katz today. He is in a voting capacity. And so Matt Ziegler,
Yes.
vote on the
Thank
MNPA minutes. Thank you. Excellent. All righty. We can now move on actually to our two action items. And so Dr. Long, will you be carrying those for us?
Yes, good morning. So good to see everybody today. Sorry if it looks like I'm looking at the wrong monitor here. There's like a million cameras in the room, so we'll do our best. So today we have two presentations, and actually the first one, the infectious disease one, my Chief Operating Officer, Chris Keeley, is going to present that one, and I'm going to present the second one.
Okay, thank you. Good morning. So this is a request for consideration. Yes.
Dr. Calamia, can you read the resolution into the record, please?
I'm sorry, I didn't hear that comment.
She was asking if you would be able to read the resolution into the record.
Sure, let me do that right now. And the resolution, first one, this is authorizing New York City Health and Hospitals Corporation, the system, to enter into standby contracts with the following 7 firms: MedRight LLC, Rapid Reliable Testing LLC, Premier Assist, the Daybreak Health Group, Inc., Somas Healthcare Providers, Inc., Fulgent Genetics, Inc., and the Executive Medical Services, the vendors, to provide infectious disease mobile response services when necessary, as directed by the system's president, with each contract to have a 2-year term for 2 6-month renewal options, and with a set of contracts not having a pre-established not to need exceed amount. Okay, thank you.
Thank you. So in late July, Health and Hospitals performed an emergency procurement for a mobile response to MPV. The term for those contracts was for 2 months, expiring at the end of this month, at the end of September 2022. A standard procurement for these and similar services was worked on in parallel, with the expectation that these contracts from this standard process will pick up where those emergency ones end off. So what we're seeking is to have these begin October 1st after the current emergency ones expire September 30th. Pricing for these services is primarily based on a per team per day basis. And for ancillary costs, vendors will be managed by existing staff under the Office of Ambulatory Care, and as always in these situations, with deep partnership from laboratory operations and nursing to ensure adequate standards are established and maintained. Otherwise, we expect no additional internal resources required. For background, we're looking for the infectious disease mobile response services to respond to significant threats that infectious disease may cause to the health and safety of New Yorkers. We're looking to contract with vendors to set operational expectations, cost structures, and reporting obligations. This type of mobile strategy is proven effective under COVID-19 and is currently operational for MPV response with 10 vehicles operational today under the emergency contracting. Ambulatory care is seeking to mitigate the spread of infectious disease, such as MPV in New York City. Ambulatory care is seeking vendors to provide testing, treatment, and vaccine capabilities for infectious diseases, including, but not limited to MPV. As some of you may recall, Dr. Long and I came before the board in late July for some COVID-specific contracts, and we were encouraged by members of the board in our future contracts of this sort to broaden the scope so that it wouldn't be just for COVID or just for testing on those types, but that we could be additionally flexible. So this contract is very intentionally designed to provide mobile services, not just for MPV and vaccination, but for any variety of services for any variety of infectious diseases. These contracts will establish commitments regarding how many units, locations a given vendor can scale up to, importantly, on what timeline they can do it, and for what services. For minimum criteria, we're looking at 5 years in business and public health services, performing similar work and deploying rapidly in an emergency response scenario. And they need to have technological infrastructure in place to generate and distribute the productivity and also the patient care reports required. As an important reminder, these vendors and this work, these will not be H&H patients. These patients here would be patients of the vendors, and they would not be within the Epic system. These would be this activity would be taking place within the vendor's medical record system. Substantive criteria, you see 35% for both relevant experience and thoroughness of plan, 20% for cost, 10% MWBE, and you see the evaluation committee here with finance, operations, emergency management. In August, we posted it to the city record and sent directly to 28 vendors. We worked through the process throughout August, and by the end, evaluation committee completed scoring of the proposals with the top 7 firms selected. You see here, we invited 8 MWBEs, 0 responded, 20 non-MWBEs, 10 of which responded, 9 met the goal, and 1 requested a waiver. You see here, of these 7 vendors, there's a number of familiar names that we've worked with in the COVID space before, as well as a couple new names. So we have worked before, or currently, with MedRite, DocGo, Premier Assist, Somos, and Fulgent. All of them, with their prior work, they've had strong operational and MWBE performance. They're continuing to work with familiar MWBE vendors for their subcontracted scope of work, everyone establishing at least a 30% target. For the new vendors for us, Daybreak and Affiliated Physicians, each of them have at least a 30% target. We've checked with their references, all have had strong positive references provided. So the Office of Ambulatory Care and Population Health is seeking approval to award contracts to these 7 firms to provide infectious disease mobile response services with a contract term of 2 years and 2 6-month renewals at the discretion of H&H. The expected start date is October 22. Health and Hospitals will require written emergency authorization from its president and CEO to activate, and then OMB will be informed of that approval, and OMB will be asked to provide agreement to cover incurred costs prior to services beginning. Clinical input will be sought and provided by both ambulatory care and medical and professional affairs prior to activating the contract. Key performance indicators will be shaped by the particular activation, but we expect they would certainly include how fast they can activate, speed to activation, timeliness of services delivered upon activation, and effective execution in the field. 2 of the simple measures of that is both the number of patients served and complaints received, but depending on those scenarios, we could imagine different types of KPIs in addition to these. It's estimated these services could cost up to $59.49 million for that potential 3-year contract. This reflects an estimated cost to activate 20 mobile teams, 7 days per week for 4 months per year for each of those years. This is intended as an emergency response, so we're not costing this out as a 12-month activation each of the 3 years. We're assuming it would be activated for some portion of each of those years, and that's how we come to this $59.49 million. Thank you for your time. Happy to answer any questions or take any guidance and feedback.
Thank you so much. Questions? Anyone?
No questions.
No questions.
All right. Let's go then to a vote. If I could, Sally Hernandez-Pinheiro
Yes.
and Dr. Martone
Yes.
and Dr. Pagan
Yes.
and Matt Siegler.
Yes.
And my vote is yes as well, Dr. Calamia. So motion carries. Let's move on to the next, and I will read that in as well. Next motion is authorizing New York City Health and Hospitals Corporation, the system, to enter into contracts with the following 5 firms: MedRite, Rapid Reliable Testing, Inc., also known as DocGo, Fulgent Genetics, Inc., Community UC, and Premier Assist, the vendors, to provide steady state and standby test to treat resources during a COVID-19 surge event, with each contract to have 1-year contract period with 1-year option to renew, and with a set of contracts that will have a not to exceed amount $156,900,000.
All right, thank you, Dr. Calamy, and thank you everybody for having us today. So by way of background on this, this was back in the summer of 2020. We became the first big city in the country to really roll out mobile units to bring equity to testing. This worked so well that we, early on in the pandemic, in which we carried through, were able to perform more per capita testing in New York City than almost any other country in the world. And a large part of that is because our mantra has always been to bring the resources that we want to offer to you. Initially it was testing, then vaccines, now test to treat, right to your doorstep. And that's what New Yorkers valued. That enabled us to be very successful in New York City. Like I said, we started with testing, then we operated a mobile vaccine fleet in New York City, which is very effective, enabled us to achieve equity. We were able to go to every NYCHA building, I think maybe even more than once for many of them, in every single school in New York, every single public school in New York City. Moving forward, now with the phase we're in the pandemic, we have a new tool in our tool belt. We have an effective life-saving treatment. And this proposal here is about how we can leverage this new life-saving treatment in the same way that we've been very successful in achieving equity in leveraging our mobile units, first for testing, next for vaccinations, and now for treatment. The treatment I'm referring to is Paxlovid. This is a very effective treatment. In the initial clinical trials, it was 89% effective. With every 18 people that were treated, 1 was prevented from getting so sick they had to go to the hospital. Since then, during Omicron in Israel, in a vaccinated population, this was studied further, and it was found that the risk of developing serious illness after you take Paxlovid in Israel during Omicron was cut in half. So these types of statistics we rarely see in terms of effectiveness of medications, but it's only as effective as the number of New Yorkers we can get it to. So what we want to do here is provide COVID-19 test to treatment capacity to achieve a steady state where we can, again, move our mobile units around, working with community-based organizations every day in New York City at a steady state, and also to have a standby capacity should we see cases go up again, so that we'd be able to very rapidly build up the capacity we need to keep our city safe. So T2 is to establish a roster of vendors with operational expectations, cost structures, and reporting obligations that can provide this test to treat capacity through the city. This would mitigate the potential need for a large-scale resource-intensive surge, because we wouldn't be building from nothing, we'd be building from something. We'd have a structure set to enable us to build very, very fast. We believe that we would need at least 30 for our steady state, though we're now thinking that we would need more than that to make sure that we're, again, every day being in many places at once and achieving equity for every neighborhood in our city. Should a surge occur, the contracts would have firm commitments out in the number of units, locations. We'd scale up for that from there as fast a timeline as possible. This would help to avoid the need for emergency procurement and contracting, of course, as well. So if we want to go to the next slide. For our contract development goals, the scope of work will have the vendor managed by our existing teams here. The vendor will staff and operate the units themselves, including the qualified clinical staff that will be on the units. They would be the ones to prescribe the Paxlovid or whatever treatment that we would have if there should be a new treatment that's developed and found to be as or more effective. And the vendor would provide all of their supplies as well. The vendors would provide proposed budgets on a per team per day basis and or on a per test and per therapeutic prescription basis. No labor costs, and there'd be no EITS impacts as well. So if we're going to go to the next slide, our RFP criteria, I'll go over this briefly. So our minimum criteria was 5 years of experience in public health testing, as long as with experience deploying rapid health services on an emergency scenario. Substantive criteria, 30% relevant experience, 30% thoroughness, 25% cost, 15% MWBE. And our evaluation criteria was broad, our committee was broad rather, including our AmCare operations team, our implementation teams, our senior operations analyst, and then also system-wide special pathogens, and of course, our director of laboratory technical operations. So if we go to the next slide for an overview of our procurement. In late June of this year, CRC approved the request to issue this RFP. On July 15th, the RFP was posted on the city record, sent directly to 28 vendors. July 28th, the pre-proposal conference was held, 17 vendors attended. August 5th was the deadline. We received 12 proposals. We then, in early to mid-August, the evaluation committee debriefed on proposal reviews, and then later in August 22nd, the evaluation committee completed scoring of the proposals, and the top 5 firms were selected. So if you want to go to the next slide. So here's this slide summarizes our Mwbe utilization. The upshot of it is that the 5 vendors selected have a goal of 30% established. We have a few notes for each one here, including prior work and strong operational and Mwbe performance. I'll read the vendors aloud now: MedRite, DocGo, Fulgent, Community UC, and Premier Assist. And again, of note, of course, all of these have the committed goal of 30%. So next slide, please. For Mnpa request today, we're here to request approval to award these contracts to these 5 vendors for establishing the baseline capacity that we know now we need. We've already done we have already treated more than 1,300 New Yorkers through this model over the last several months, and we've completed more than 40,000 tests of New Yorkers. So it does exist today. It is working very effectively today, and we want to establish a baseline to continue its effectiveness. Then, of course, with the standby capacity as well, for the initial and renewal terms totaling 2 years for not to exceed of $156.9 million. For the contract term, it would be 1 year with 1 year renewal option at the discretion of New York City Health and Hospitals. Of note, this figure anticipates the need to bear the cost of purchasing the therapeutics starting in October of 2022. If that should not need to be the case, and if there were other mechanisms for receiving the therapeutics at no charge or cost, that would lower the actual expense to $127.3 million. The expenses will be covered by the T2 MOU between OMB and New York City Health and Hospitals. The city will receive approval from OMB before activating any surge vendors. So with that summarizes our proposal. Thank you again for having us today, and look forward to answering any questions.
Thank you so much, Ted. Questions, anyone?
Hi, Ted. Excellent. So just a quick comment that, so when these contracts get activated, this one and the other one, just to clarify that we will be, that information will be provided to the board, right? When those contracts are activated? Okay,
absolutely.
So I just want to put that on the record that we will be notified that the contracts are activated when that happens.
Yep. Thanks, Dr. Pagan. Will do.
Okay. Thank you.
Thank you. Any other comments, questions? All right. If there are none, let me go to the vote then.
Oh, sorry, I
I'm
had a
sorry.
question.
Sally, go ahead. I'm sorry.
Yeah, sorry, I was on mute. I was just comparing the 2 contracts, and the second contract is about 3 times as expensive. Is it because of the staffing level required? And it's only 2 years. Is it the staffing level that's required?
Yeah, Sally, that's exactly right. And just to give you an example here, so the way this model works is you go up to one of our mobile units, you receive a rapid test or a staff to do that. If it's positive, you shift over to the side. There's a clinician there, and they're going to evaluate you for eligibility for Paxlovid. They prescribe it, and then there's additional staff that actually will hand you Paxlovid. So it's about a 20 to 30 minute experience for you from when you walk up to the unit to when you literally walk away in your hand with Paxlovid, a medication that could save your life. So it's more staff intensive because it's sort of, we're creating a one-stop shop experience.
Right. You don't have the drugstores, which you were using for a while. The second question is, I noticed that Somos is not part of the group that was selected. Did they apply? Were they rejected?
The test to treat, I believe they may have applied.
Yeah, these are the 5 that our scoring committee scored the highest.
Okay, thank you.
And one other brief note I want to make on the finances, just I know that we'll also be going to the board, so just later on this month. So also just to underscore, one of the other differences between these 2 contracts or these 2 proposals here is the prior one that I spoke to around the infectious disease. That's assuming we're only activating 3 months out of every year. Whereas the test to treat that Dr. Long just spoke to, that's assuming a full year, 12-month activation. So that's also part of the difference in finances.
Okay, and it's your intention to activate both of those immediately, both contracts?
Yeah, for the test to treat, we want to maintain a baseline of these. Right now, today, Sally, we have 30 of these units that exist in our communities today. And we actually have additional units that are our Street Health Outreach and Wellness Program, which are the ones that are focused on providing Paxlovid to people that are unhoused in New York City. But the 30 units that we have today, this contract would allow us to continue that at least a fleet of that size. We're planning on a larger fleet that would be available every day to New Yorkers as a sort of standard capacity, if you will, as long as COVID remains a threat.
Sorry, my last question, sorry to keep.
Yeah, please.
So the, your experience with the utilization, has it been consistent, increasing? Utilization?
Yeah, I would say, great questioning. So we announced this at the very end of June, this model. This contract allows us to continue the model that we've started now. But since we announced it at the end of June, in just a matter of months, we've completed more than 40,000 tests and successfully treated more than 1,300 New Yorkers. We've seen over time, each of the units we've started has gained popularity. In other words, people are voting with their feet and coming to these units every day. It's been very successful, and I'll give you a quick patient anecdote for you. The first patient that we saw treated with this new model was a lady who had been exposed to somebody with COVID, had symptoms, but didn't have a cell phone. And she figured, you know, she wouldn't necessarily want to get tested if she couldn't call anybody for help because she didn't have a cell phone. But when she saw that she could come to our units, get tested and treated in a single experience, she came, she tested positive, and she walked away with the medication that could save her life. And she knew she had COVID, so she didn't risk infecting others. So that's really the power of our model. And people are voting with their feet and coming out to get tested today.
Thank you, Ted.
Thanks, Sally.
Great. Any other questions, comments? Sally, let's start with you then on the vote.
Yes.
All right, Dr. Marchon,
Yes.
Matt Ziegler,
Yes.
Dr. Pagan,
Yes.
and Dr. Calamia. I'm voting as well in favor, so the motion carries. Thank you so much. Thanks for the excellent presentations. All right, if we can go on. Thank you. Let's go on then to our reports, and we'll start with the CMO report. It's being delivered by Dr. Manish Parikh, Chief of Perioperative Services at Bellevue and Clinical Service Lead for the system, and he'll be presenting on behalf of Dr. Michelle Allen.
Okay, good morning. Dr. Allen asked me to give her an update on the peri-op across H&H. Go to the next slide. Next one. So I think just taking a step back, one thing that COVID allowed us to do, since we had to close most of the ORs, is to kind of rebuild some of the processes, and it starts with the data. And since we went live with Epic across H&H starting in 2019, we're able to standardize some definitions for metrics as it pertains to the operating room, specifically first case start, which is when the patient enters the operating room, and we standardize reasons for delays. Keep going. How a cancellation is defined, which is a scheduled procedure, same day not performed, and utilization, specifically how is a room utilized, how is the block utilized, and how we define prime time, which is the key staffing time when nurses and anesthesia are staffing the rooms, and then turnover time, which is defined as wheels out to wheels in. So after standardizing these metrics, we actually then created a weekly tracker. This is an example for the main OR and endo and cardiac cath locations across H&H, with basically a weekly volume based on patient class, which is whether the patient is being admitted, whether the patient's already an inpatient, or whether the patient's an outpatient, first case start, same day cancellation, the utilization and turnover time, and TP is throughput, which refers to it's a crude measure of cases getting booked versus getting done to make sure there's no delay in patients getting into the operating room. And you can see, especially on the left for the main OR, which is where most of the work has been over the last couple of years, the reds, we kind of created a heat map, which is where we started right before COVID, And then over the last couple of years, really have made a concerted effort to improve the operational metrics and improve access to the OR, which is translated to increased volume. And some of the other processes we rebuilt was changing pre-admission testing for patients who are undergoing surgery. In many hospitals, it was mandatory for every patient. We used more evidence-based guidelines to transition that to a selective pre-admission testing, and that was using Epic, specifically how cases get booked. There's a lot of variation in how cases get booked, so we standardized how cases get booked to determine who goes to pre-admission testing and what tests specifically need to be ordered. Keep going. We also spent a lot of work on nurse staffing models for the operating room, and we are now also starting with working on anesthesia staffing models, because these are obviously key for capacity for the OR. And so the question was raised about whether this is delivered into any positive revenue for the corporation. It has. This is fiscal year 22 versus 21 variance. And the bottom line is, with all these process improvements, is translated to almost 7,500 additional cases in the past year, which is translated to about almost 70 million in additional revenue. And if you take the net, actually it's 85 million additional revenue. You take the net of investment in business plans and some of the way rates are calculated, it's a little over 50 million. And finally, we're now focusing also on expanding robotic surgery across H&H. We want to capture patients that are being sent out of the system and be able to convert existing open procedures to minimally invasive. It provides better access for patient care. It allows a lot of hospitals to recruit surgeons. And so we're in the process of expanding robotic surgery currently.
Thank you. Thank you, Dr. Preek. Just curiosity. So the increased volume, that's basically been pretty much keeping the overhead and staffing because of the improved efficiency fairly constant, or how has that worked out?
Yes, a lot of it is just efficiencies. There's been some investment in the OR too with business plans, but a lot of this has been from efficiency and making better use of the existing staff and time.
And is that reduced, for example, the problematic bump rates where we have to bump elective cases, on behalf of in-hospital? Has it had an impact on those issues?
Yes, I think it's made a major impact, because what you're alluding to, where some of the emergencies are urgent add-ons, if they can't get done, they also sit in the hospital and they occupy a hospital bed. The hospitals are full, so we really want to improve the access to the OR, and that's what a lot of this work has been focused on.
Super. All right. Other questions? Sally, any questions you have?
No, thank you.
Okay. And Dr. Martone, any comments, questions?
No, thanks.
And Dr. Pagan?
No questions. Looks good. Thanks.
It really does. And Matt, any comments or questions?
I guess I will for a minute, just to praise Dr. Parikh and Dr. Allen and Kenra and Chris Roker and the whole team for doing this. It really did start when we were just barely coming out of the COVID surge, and so to turn on a dime to really make these type of operational improvements at that time was a big deal, and they've really carried it through. So thank you on behalf of Dr. Katz in a voting capacity.
Yes, superb. I couldn't agree more. And I think the reality is, again, it's wonderful for our bottom line, but just for patient comfort, quality of care, outcomes, all these things are significantly impacted. So bravo. Great work for sure. All right. Any other comments, questions? Otherwise, can we move on then to the Chief Nursing Office report? And Dr. Sinez?
Sure. Good morning. I will keep nursing's report very brief this morning. Right now, we have a group of nurse leaders and frontline staff in Tarrytown, New York, presenting our work. We are very proud that we've won 2 years in a row now the Claire Murray Best Practice Award at the New York Organization of Nurse Executive and Leaders Conference. So you see on the slide, we have 6 presentations happening, and home care again has won. So I'm very, very excited. And Bellevue is also showcasing their ECMO program. So very proud of that. Next slide. We've also been accepted in some journal articles across the nation, which is a big deal for nursing. So we have 3 published manuscripts as of May of 2022 this year. And these are the links where you can read these articles. And I'm very proud of the 3rd article on this slide, which is really demonstrating the work that we will be doing within the Future of Nursing Report 2020-2030. And this is a very important report that's published by the IOM every decade. And so we have outlined the work that nursing will be doing within the next 10 years here at Health and Hospitals. So again, this is our work for dissemination and for reading. And then the remaining of our report is just highlighting the different pillars and the work that we continue to do across the system. But I just wanted to highlight the first 2 slides today. Thank you.
Thank you so
I'll
much.
take it.
Ken, questions?
I just had a question about your Behavioral Health Associate Academy. You know, we read some concerns about Metropolitan and their behavioral health unit. How long is the program and what does the pipeline look like?
So that's an excellent question, Sally. So the behavioral health program is in partnership with Mnpa and nursing, and it's over a month. And essentially, we started it out as a pilot, and the goal was to hire over 200 BHAs across the system. And as you can see on this slide, we've had several cohorts go through. We've been extremely successful with the graduates, but the goal is also to train all of our incumbent BHAs in addition to the new ones coming in. And that's going to take some time. And so we've invested in different instructors here at Central Office to ensure that we're working in parallel paths. So not only the new BHAs that we're hiring, but those who are here within the system are getting the same training. And I think that's really important. At Metropolitan, we're doing culture of safety meetings every month because it's more than just the BHAs at Met. There are different layers of support that Metropolitan needs. And we are working with them diligently and Christina Contreras to make sure that we provide them with that level of support. But so far, the BHA Academy has been extremely successful in partnership with the union as well. But there's more work to be done.
Terrific. Thank you so much.
You're welcome.
Thank you. Any other questions? Dr. Martone, any questions or comments?
No, thank you.
Thank you. And Dr. Pagan?
Just want to, commend you for for disseminating basically the work that is going around health equity and the whole thing about nursing leadership and so on, because it's important for that other systems learn about that work and that you're following the National Academy's recommendations and so on and spreading the word on that. So just wanted to say that, and I have 3 more papers to read this week. So
Thank you. We figured why not lead the pack? Yeah.
Thanks.
Thank you.
Thank you. Matt, any comments? Matt Ziegler?
No, thank you.
All right, super. All right, thanks so much for that superb report, and bravo on the great work you're doing. Lastly, we have our Metro Plus report with Dr. Schwartz.
Good morning. Apologies for not being able to be there in person. So quick update on the IRA, Inflation Reduction Act, and what it means for our industry and for our members. So as it relates to the marketplace consumers, specifically the QHP consumers, we were very happy to see that the subsidies were extended through 2025 for individuals who spend more than 8.5% of their income on paying premiums. We were concerned that a lot of people in this category will find the coverage not affordable without the subsidies, so that's an important decision. I'm sure the members of the committee and others heard about the ability now, well, not now, in 2026, of CMS to negotiate some of the drug prices, not all, but some, so that's important. Additionally, capping the out-of-pocket expenses for Part D. Again, we know that some of the seniors have been spending a significant amount of money just on the out-of-pocket portion, so capping at $2,000 is critical, and that starts in 2024. And finally, requirement to cover without out of cost any expenses, all of the adult vaccines that are recommended by the Advisory Committee on Immunization Practices. Next slide, please. In terms of our membership, we continue to see higher than expected growth. We are very, very close to 680,000 members at this point, and we are 1.7% higher than projected for this time period. We have heard recently that the recertifications were extended for all of the Medicaid beneficiaries through the end of November. So the end of November of 22 will be extended a full year through November of 2023. Next slide, please. Just want to highlight the middle bullet point here on Qhp. The Qhp rates were finalized and approved by DFS for 2023. Metro Plus Qhp will be the most affordable plan in the state, despite the increase. It was a very, very modest increase compared to others and compared to the inflation and increased medical expenses. And so we are currently the most affordable plan in all metal levels except for one. And we project that in 2023, we'll be the most affordable health plan for all metal levels. Next slide, please. This issue has been covered significantly relating to the asylum seekers. We have been collaborating with Health and Hospitals, Lincoln Center specifically, and various city agencies to welcome the asylum seekers, and from our perspective to make sure that they have appropriate health coverage. I'm happy to share that to date we insured over 1,700 of the asylum seekers, and we have one additional event that's planned in 2 weeks from now, where we expect thousands more to attend, and so we expect those numbers to grow significantly. Next slide. Another update, and there are more updates since this slide. We have seen a significant improvement on our CAP surveys for Medicare beneficiaries. We have been traditionally performing very, very, very strongly on the clinical measures, but have been lagging on the CAPS measures, which essentially measure the consumer satisfaction. We put in kind of a dedicated team and dedicated efforts around consumer satisfaction and decided to focus on Medicare because of the time that we implemented the program, and also because of the size of this product. We have approximately 10,000 members in the Medicare line of business. Since we put the efforts in place over a course of 6 months, we have seen significant improvement in the CAP scores from 21 to 22. We improved on all of the measures except for 2, and some of the improvements were quite significant. The lagging 2 measures are getting appointments quickly, and our customer service, and those are being worked on intensely. But I'm happy to report that the other measures improved significantly. And at this point, I wasn't ready to share this when we shared the slide deck, but I'm happy to share that this improvement in CAPS ultimately drove our entire star performance, and we moved from a 3.5 Medicare plan to become a 4-star Medicare plan. Next slide. These are just some of the highlights in terms of what have we done to really improve the CAP scores. It didn't happen by itself. It took a very intentional type of intervention. It's not rocket science. It just requires a specific attention to the needs of our members. So we were really trying to figure out what specifically do our members need. And I will tell you, when we started this effort, it was early in 2022 when the Omicron wave was out of control and there are lines of people spending blocks and blocks to go and get tested. We understood that Medicare members, for example, obviously could not stand in the cold and wait to get tested. So we procured COVID testing kits and sent it to our Medicare beneficiaries so they could actually test themselves and see what their status was and whether they needed treatment or not. Just one example. Additionally, we did quite a bit of coordination. We realized that many of the areas at the plan were reaching out to our members, but not in a coordinated fashion. So sometimes there is such a thing as too much of a good thing. So coordinating between different areas and streamlining how we are outreaching to our members certainly improved their experience as well. One of the things we've done was following up with our members after they had appointments to make sure that they understood what happened at the appointments, doing pre-appointment prep, making sure that they know what to focus on, what to ask, and having a checklist, and then post-appointment contact to make sure that they understand what occurred during the appointment and resolving any issues they might have had or any misunderstandings that they might have had. Next slide, please. Just to alert the committee, at this point, the state is having multiple meetings with various stakeholders, including the plans, in preparation for the pharmacy benefit transition to fee-for-service from managed Medicaid. So currently, managed Medicare is administering the pharmacy benefit for beneficiaries in both in Medicaid, in Qhp, and as well as the long-term plans and essential plans. And there is a plan, or there are intense conversations about moving those services back to the state and administering them as fee-for-service. There are significant concerns by multiple stakeholders around this carve-out. Some of the main concerns that we have is inability to assist members with resolving point-of-sale pharmacy rejections, something that we do currently. Obviously, we're responsible for coordination of care. How do we do that coordination of care without pharmacy being available to us in essentially real time, which is what we have right now? The inability to access timely pharmacy claims, although the state is claiming that the plans will receive the pharmacy claims in a timely fashion, we know that that will not be as timely as it needs to be. There are many other issues around this move. There is significant advocacy against moving the pharmacy into fee-for-service. And we continue to push against it, and are hopeful that in the end this will not occur. We do not think that there are any kind of savings associated with moving pharmacy to fee-for-service, which is the main reason for why the state wants to move it back to fee-for-service. And we think there are significant negative impacts to members and to care management. Next slide, please. Another update that I wanted to share with the committee, and again, there was a change since this slide has been shared. It doesn't apply to pharmacies any longer. There was a clarification by the state just last week. It does apply to providers, and essentially the state is prohibiting the plans paying providers who are not enrolled in New York State as fee-for-service providers. Currently, we have almost 1,600 providers who are not enrolled with New York State Medicaid. And so we are currently, as of September 1st, are not able to pay their claims. There's a specific concern here where residents and interns obviously take care of many of the members, including at health and hospitals. And if any claims are coming from residents or interns, the plans are not allowed to make a payment. We are working on a solution around it, but in the end, this is quite problematic, and I wanted to bring this up to the committee's attention, and we're also working separately, specifically with health and hospitals, to make sure that all of the submissions ultimately are submitted under the attending ID, and so that the plans are able to process all of those claims. Next slide, please. At the end of this month, we will celebrate our 1-year anniversary of bringing behavioral health in-house. And I wanted to provide the committee a very, very brief update. So we've been working directly with H&H Behavioral Health, and we are getting ready to deploy our care managers in various facilities at health and hospitals. Our care managers will be assisting with transitions of care, with placing members where they need to go depending on their needs, with social determinants of health, with quality measures, and also for those who are interested transitioning from the mainstream Medicaid into the HARP line of business where more services are available to them. Next slide, please. Just to share very early notable utilization trends. So what we have seen since we transitioned behavioral in-house is a decrease in inpatient mental health average length of stay by 3 days, from 15 days to 12 days. We also have seen a decrease in 30-day readmission rate for inpatient mental health. For the HARP line of business, decreased from 26% to 19%, and for the Medicaid line of business, for 21% to 14%. We haven't seen significant change in length of stay for substance abuse admissions, but we are working with the most prominent and highest volume facilities to address the issues there, making sure that people are started on MAT before they get discharged and continue on MAT before they get discharged. There's also a lot of work that's happening with H&H, since H&H has significant MAT capacity. What's not noted here, besides the decrease in acute services, we also have seen an increase in outpatient services, which is obviously something we strive to see. And lastly, the plan is participating in disseminating what we call Project Teach. This project was launched by OMH, and this is really to increase mental health capacity among PCPs who provide services to children. So essentially, it is supporting pediatricians and other providers who provide services to children with mild and moderate mental health illness, through telephonic consultation, face-to-face evaluation, linkages, training, whatever the providers need to be more comfortable and provide those services directly, since we all know there's quite a significant shortage and access barriers, especially to pediatric mental health. And that concludes my report.
Fabulous report. Let me go individually for questions and comments. Excuse me, Sally Hernandez Pinheiro. Questions, comments?
No, I just thought it would be worth noting that when the waiver and recertification ends in November, we've been preparing for the kind of onslaught of recertifications we'll be seeing. That's all. Hello? Hello? I lost them.
Together, I hear
We
you.
hear you, Sally.
Oh, okay, great. So I just thought it was important to note that there's there's going to be a big wave of recertifications once the waiver is no longer granted, and that Metro Plus has been preparing extensively for that.
Dr. Calamia, you may be muted. We hear you, we see you speaking, but we don't hear you.
That's worrisome to me. I'm not to maybe Jose. Try to reboot.
I can hear you, but it's very faint. So
Jose, Dr. Calamia is having an issue. Can you please close out the meeting, request the other comments, and close out the meeting? Thank you.
Yeah, I'll do that in a second. So I have a quick comment on the caps. I don't know if you can hear me.
Yes.
Tali. You mentioned for the Medicare line that the only issue that didn't improve from 21 to 22 was getting appointments and customer care. On getting appointments, I guess you can do something about that in terms of the care that people get at beneficiaries get at H&H, right? And I would like to hear more about that, or ways in which we can improve that. On the customer care side, is that related to customer care that you provide or that H&H provides?
So on getting appointments quickly, you're right. There are things that we can do, and we have been in communication with H&H, as well as really promoting express care and telemedicine in general. Really making sure that our members understand when it is appropriate to use express care. We actually had a members advisory committee where we invited a bunch of our members, and it was surprising to us. While we think everybody knows about telemedicine, knows how to access it, knows what it's all about, that some people knew about it but didn't really understand what it meant, and some people just didn't feel comfortable using it. So yes, a conversation with H&H on access to care, and also specifically around express care. In terms of the customer service, we think it's not always completely clear, but we do think it relates to our call center. And so we now have an entire slew of activities to improve it. One of the most important things we implemented is a specific dashboard per representative in the call center. So every member who calls into the call center is asked to complete a very quick survey, which we had for years and years, but now we have a dashboard that is rep specific. And so we can see which reps are performing really well and which reps require kind of re-education and retraining. And so we're able to be much more targeted and improve our performance there.
So congratulations on all the improvements, and I think I'm sure board members would appreciate if you can report next time on any progress on those two areas, or any insights, over the next few months. I think, yeah, I don't know if everyone had a chance to ask questions, Dr. Martone.
Yes, I would like to, thank you, Jose.
Right.
In fact, it's within the same topic that Jose just asked the question. And the customer service, okay, I kind of understand. Maybe you'll come back with a more, a deeper dive on what that means, because I would love to get clarity around which customer service exactly we're talking about here. And then the other end was appointments and care quickly. So for that, I would really appreciate understanding at what point the customer or the patient is saying that there's a problem. You know, where is their breakdown? They pick up the phone, they make the first phone call, there's no providers available. Like, what is it? And what does your deep dive look like on that? Because to me, it's very important. It's a driving force in patient care, and I really would appreciate understanding exactly what that means from your perspective.
Yeah, I'm happy to bring a deep dive. We have a lot of insights around this. We've been looking at this for quite a while. So I'm happy to bring this to the next Mnpa and dig into this deeper.
Thank you. And also wonderful, I love to see the decrease on patient days for behavioral health. I hope the discharge planning reflects the care that they got while they were in, and these patients are truly carrying on with good quality care. But great job. Thank you.
Okay, any other questions or comments from board members? Matt, I don't know if you had any.
Nope, Talia and I work closely on all these things, so we're in sync, and you know, a lot of progress still to do, but great results here.
Thank you. Okay, any other questions or issues to come before the committee? Well, hearing none, then the meeting is adjourned. Thank you so much.
Yeah.
You.
Bye.
Thank you.